Okay, in this short video, I'm going to use this digital model of a kidney to explain the plane of section that we were working with in the kidney histology lab this past week. Now, we're looking at the kidney in anatomical position, which means that if our patient was in front of us and we were looking into their abdomen with X-ray vision so we could see the kidney, it would be standing like so against their posterior abdominal wall with the lateral margin here and the medial margin here. And if I rotate it a bit, we can see that the hilum is going to be located at that medial margin. This is where the vasculature is entering and exiting. And of course, the ureter would have been exiting out here as well. And it's this coronal view which is going to be used, which is what is used in virtually every resource that you go to learn about the kidney. So all my histology textbooks present the kidney in this dimension with, of course, a coronal cut right down through the entire organ. And the reason that this coronal view is used so often everywhere is because it shows all of these important features of kidney structure in one convenient plane of section. Now, I built my geometry here in about 15 minutes because I was in a rush to get this out to students. But you want to keep in mind that around each one of these renal pyramids at the papilla, right, at the apex where the renal papilla is, you're going to have the beginning of that large urinary transport system. So you're going to have your minor calyx capping each of these renal papillae. Each of those minor calyces is going to feed into a major calyx. There'll be several major calyces that all feed into a single renal pelvis. And from the renal pelvis, the ureter will continue on to descend towards the pelvic cavity, right? So I don't have that modeled in, but you need to use your imagination. Remember that it's there. And that's okay. That's not the point of this video. The video is to explain the appearance of these renal pyramids depending on the plane of section we use. So the textbooks use this coronal cut, and when you look at the renal pyramids, each renal pyramid, it looks pyramidal. It looks triangular. There's a very clear apex here and a very clear base right here. And even though that base is curving a little bit, we can kind of just imagine that that's pretty flat-like, right? So it looks like the profile of, the Pyramid of Giza. And the reason that the bases of each one of these renal pyramids looks nice and flat here is because that corticomedullary junction is running parallel to the capsule. And the capsule of the kidney itself, when you look at this profile, the curvature isn't particularly steep. So if you just look at a single patch of the capsular surface, just like the corticomedullary junction, you match it up with the pyramid, it looks kind of straight, just like that looks kind of straight. Okay? Now, this is convenient for teaching students in a textbook, but in a clinical setting, you're very rarely going to get a section coronally through a kidney. And the reason for that is, well, one, in living patients, you're going to kill the kidney doing that. You're going to, cut somebody's kidney in half. Never going to do that. But even in a postmortem situation, the reason why we don't get this that often, the average length from superior to inferior, right, of an adult human kidney is about 11 centimeters, which means that your microscope slide has to be at least 11 centimeters in length. And that's really long. So a lot of clinical operations don't stock giant plates of glass to plate this much tissue on, okay? Or at least not for kidney purposes. Clinically, you're not going to get that kind of section. Instead, if you want to do a biopsy of the kidney, most of the time you're doing punches, but every once in a while, a larger block might be needed. So instead of doing the coronal cut, what often happens is that we get a transverse cut. And that's what we had in our lab this week. So a transverse cut would be if I were to cut like so. And let me go ahead and do that digitally. And we'll look after I institute that cut. I'll rotate it and show you the surface of the tissue, and we can see how that's going to change the shape of our renal pyramid. Right? So that's the kind of cut that you would be more likely to see in a clinical setting because it produces a smaller, in terms of surface area, tissue section. Right? And if I rotate it now so that we look at that renal pyramid, look what happened to the shape of the base. Instead of having a flat base, or more or less flat base, opposite the apex, we have a curved base to that medullary pyramid. That's our corticomedullary junction. And it's no longer nice and flat like all the textbooks tell us it should look. Okay? And the reason it's curving is because, remember, the corticomedullary junction is curving parallel with the surface of the organ. And the curvature of the kidney from posterior to anterior is much more pronounced than from superior down to inferior. And it just distorts the appearance of that junction for us. But that's kind of more likely like what you're going to get in a clinical setting. And even in a clinical setting, you probably wouldn't get all of the profile. What they would do is they would block the kidney, they would do that cut, and then they would block it even further by taking a wedge out of this tissue. But the result is the same. You're going to get a blocked biopsy tissue section that has a curved corticomedullary junction in it. And it's not the result of a pathological process, a tumor pushing tissue or something like that. That is just an artifact of the plane of section. Okay, one last thing I can do, if you want to see, is I can just, there we go, just isolate the renal pyramids without any of the cortical tissue in the way, and just rotating it, you can see how the shape of this is not truly pyramidal like the pyramids in Egypt. We've got a shallower curvature here and a much more curved surface there. Okay, there you go.